Imagine someone walking into your bedroom right now. Like, they just walk right in.
Oh, wow, yeah. That is unsettling.
Right, and they start digging through your closet, pulling out your favorite clothes, and just tossing them aside.
Just completely ignoring your personal space.
Exactly. Then they hand you a faded, backless, generic hospital gown, like a one that maybe even has someone else's name written in faded Sharpie on the collar.
Oh, I know exactly the kind you mean.
And they look you in the eye and tell you, this is what you're wearing to breakfast today. Let's go.
I mean, for a lot of people, that absolute stripping of identity and choice is the ultimate fear when they think about moving into long-term care.
It really is. It's the fear of becoming a task instead of a person, like a room number instead of a human being.
Yeah, that's exactly it.
Welcome back to The Deep Dive. We are incredibly glad you're here with us today. If you are joining us for the first time, this is the CERT Prep Academy CNA Exam Prep Series.
Yep, we are systematically breaking down all 6 of the NNAAP written exam topics.
Right, over the course of 11 deep dives. And just so you know, every single one of these conversations stands completely alone.
Which is great because you can jump around.
Exactly. You can find the exact clinical or ethical topic you need to brush up on and just dive right in.
Which really is the smartest way to study. You identify your weak points and you attack them directly rather than just, rereading the whole textbook from front to back.
100%. And today we are on episode 9 of the series, and our mission is a massive one. We are diving deep into resident rights and OBRA.
It's a huge topic.
It is. Now, before we get into the weeds, let's establish the stakes for you, the listener, sitting there prepping for your exam. If we look at the official written exam content outline...
Which is the gold standard, by the way.
Right. It remains the absolute gold standard for how this test is engineered. Well, client rights makes up about 7% of the exam, and legal and ethical behavior makes up another 3%.
So when you do the math, we were talking about roughly 6 questions total on your 70-question exam.
Right. And I know exactly what people are thinking when they hear that. They're like, 6 questions, that's barely anything.
Yeah, they think it's not worth studying.
Exactly. They think, I'm going to spend my weekend memorizing the exact water temperatures for a bed bath and, how to empty a catheter bag. I know how to be nice to people. I'll just guess on the rights questions.
And that is exactly where the test makers are waiting for you.
It's a trap.
It completely is.
Yeah.
Because here is the secret about these 6 questions. They are rarely straightforward definitions. They're almost entirely scenario-based.
Yep.
The exam is going to present you with a complex, messy, real-world situation, maybe involving a resident, a frustrated family member, or a stressed-out coworker. And it will ask you what your next immediate action should be. They aren't testing your vocabulary. They are testing your applied clinical judgment.
Right. You cannot just memorize a dictionary definition of a word like autonomy.
No, you have to understand the underlying philosophy of person-centered care well enough to apply it when a resident is screaming.
Or a daughter is crying.
Right. Or a coworker is pressuring you to cut a corner.
I see this exact dynamic play out constantly. I mean, this is a topic that comes up constantly on CERT Prep Academy practice tests because it really separates the test takers who just memorized facts from the ones who truly understand person-centered care.
Absolutely. If you just try to guess based on what sounds, polite or helpful in a normal customer service setting, you are going to get caught by the distractors.
Because the wrong answers on this exam are brilliant.
They really are. They're engineered specifically to appeal to your natural human instincts.
Like the instinct to please an anxious family member.
Exactly. Or the instinct to prioritize physical safety over everything else. Or even just the instinct to get a task done quickly because you have 10 other residents waiting.
Oh, man, yeah. So today, we are going to dismantle those traps one by one. We are going to be your study partners for the next hour or so. We've got our coffee. We've got the source material in front of us. So let's just get comfortable and start unpacking this.
Sounds good.
To truly understand resident rights, I think we have to start with the big picture, like the history. Why do we even have a formalized, legally binding list of resident rights in long-term care?
That's a great question.
Because on the surface, having a federal law telling healthcare workers to treat people with respect seems a little obvious. Why was this necessary?
Well, to understand the why, we really have to rewind the clock. We need to talk about what nursing homes were actually like in the 1970s and early 1980s.
Okay.
This was before a massive piece of legislation called OBRA was passed. That's the Omnibus Budget Reconciliation Act of 1987.
Right.
If you walked into a facility back then, you would often see conditions that were fundamentally dehumanizing.
We're talking about a very clinical, almost warehouse-like model of care. Yeah.
Exactly. It was a purely medical institutional model. Residents were often viewed as patients to be managed rather than people living the final chapters of their lives. Chemical restraints were rampant. That means giving people heavy sedatives just to keep them quiet and compliant.
That's horrifying.
And physical restraints, too, like tying someone to a wheelchair so they wouldn't wander. That was just common practice. Residents had virtually no say in when they woke up, what they ate, or who they shared a room with. The schedule of the facility was the absolute dictator of their lives.
So, when a test question brings up the fundamental purpose of resident rights under OBRA, it's not just a generic statement about being kind. It's a direct response to a very dark history.
Precisely. The core mandate of OBRA 87 was a paradigm shift. It established that entering a nursing home does not mean you check your constitutional or human rights at the front door.
That's such an important point.
And the exam frequently tests this foundational concept. The primary purpose of these rights is to ensure that residents maintain their dignity, their autonomy, and their quality of life. The law made ethical care just as legally enforceable as clinical care.
Okay, I want to zero in on that word you just used, autonomy. It gets thrown around constantly in healthcare marketing, like it sounds wonderful on a glossy brochure. But what does autonomy actually look like in practice for a CNA working a Tuesday morning shift?
It means the resident is the author of their own daily life. Autonomy is the daily reality of a resident making choices about their own care, their own schedule, and their own personal matters.
Okay.
It is the direct opposite of institutionalization. Autonomy means you don't force a resident out of bed at 5:30 in the morning just because it's easier for the first shift to get baths done before breakfast.
Right.
I mean, the resident decides if they want to wake up at 8 a.m., whether they want eggs or oatmeal, whether they wear the blue sweater or the red cardigan, and who they want to sit next to in the dining room.
I've always liked this analogy. Moving into a long-term care facility is really like moving into a new apartment complex that just happens to have built-in medical support and a cafeteria.
That's a great way to think about it.
You don't surrender your right to control your own life when you sign a lease for an apartment. You shouldn't surrender it when you enter an assisted living or skilled nursing facility either.
That is the perfect mental framework for the exam. In fact, the test makers love to present scenarios to verify you understand this. They'll ask you to identify the most accurate statement regarding resident rights upon admission.
And the correct concept they want you to identify is that residents retain their full rights to make decisions about their care and personal matters.
Exactly.
Okay, let's unpack this because I have to push back a bit, or at least play the role of the skeptical family member or nervous test taker. This is where the exam gets incredibly tricky.
Bring it on.
What if the resident has advanced Alzheimer's disease?
Yes.
What if they literally cannot verbally communicate with you and they don't know what year it is? Do they really still have that same level of autonomy?
Practically speaking, how do you balance their sheer physical safety with this concept of autonomy? This is arguably the single most critical caveat on the entire CNA exam. Yes, they absolutely retain their rights.
Even with severe dementia.
Even then, a cognitive impairment changes the method by which a resident exercises their rights. Perhaps they are communicating their preferences through their behaviors, their body language, or their facial expressions instead of using words. But the disease does not erase the rights themselves.
The exam will aggressively try to trap you on this exact point. You'll see a scenario where a resident with advanced dementia cannot communicate verbally, and it will ask what is most important for the CNA to prioritize.
Yep.
And one of the wrong answer choices will be something like, only residents with full mental capacity have rights, or the primary focus must be solely on following the doctor's orders for safety.
And you can completely understand why a nervous student under the pressure of a ticking clock would pick that.
Right, because human instinct says, well, if they have dementia, they can't make safe choices. Therefore, the staff has to step in and make all the decisions to protect them. Their rights are basically suspended for their own good.
But that is a fatal exam mistake.
Slightly fatal.
It stems from a paternalistic mindset that the test specifically wants to weed out. The correct answer in those scenarios always centers on the fact that the resident retains their right to privacy, dignity, and respect, regardless of their cognitive condition.
So safety doesn't trump dignity.
No, In person-centered care, safety and dignity have to coexist.
Hmm.
You never, ever sacrifice a resident's basic human respect just because their brain is physically changing.
That is such an important foundation. And if we accept that the resident maintains full autonomy and ownership over their life, that naturally leads us to the most tangible physical way CNAs interact with those rights every single day.
You mean the physical boundaries of the body?
Yes, physical privacy and modesty. We are talking about the daily mechanics of care. The doors, the shower curtains, the bath blankets, the bedpans.
The everyday stuff.
Right. If autonomy is the overarching philosophy, physical privacy is the execution of that philosophy.
Privacy during personal care is completely non-negotiable. We are talking about assisting with bathing, toileting, and dressing. Think about how inherently physically vulnerable a person is when they are naked, relying on a stranger.
Or even a staff member they know well.
Exactly, relying on them to help them wash their body or use a toilet.
I try to actively put myself in their position. Like, if I were recovering from a stroke and relying on someone else to help me with my most intimate hygiene needs, I would be hyper aware of every single person who walked past my door.
Oh, absolutely.
I would be terrified of being exposed.
Mm.
So what are the specific measurable actions the exam wants to see the CNA taking to protect this physical privacy?
The exam is looking for standard, proactive privacy measures. It's not enough to just cover someone up if someone else walks in.
You have to prevent it.
Right? You have to build a fortress of privacy before you even begin the care. There are scenarios on the test where you are assisting a resident with bathing, and the resident explicitly asks you to close the bathroom door and pull the shower curtain completely shut.
Okay.
The question will ask what this request demonstrates.
And the correct answer is the most beautifully simple one. The resident is exercising their fundamental right to privacy and dignity.
Exactly. But look at how insidious the wrong answers are for a scenario like that. One distractor might say, the resident is trying to hide something inappropriate from the staff.
Oh, wow.
Or another might suggest, the resident needs a psychological evaluation for paranoia.
It sounds almost comical when we say it out loud in a quiet room, but they put those distractors there to test your clinical mindset.
They do.
Like, are you viewing the resident as an adversary? Are you viewing a normal human desire for a closed door during a shower as a behavioral problem? A resident wanting the door closed is the most normal, rational request in the world.
It truly is. And the burden is entirely on the CNA to initiate that privacy. You should never be waiting for the resident to feel uncomfortable enough to ask you to close the blinds.
Right, you take the lead on that.
Always.
Mhm.
You should be knocking before crossing the threshold of their room, waiting for them to grant you permission to enter, and pulling the privacy curtain completely around the bed so it overlaps before you untie a single string on their gown.
Oh, and let's not forget how we address them. This is a huge part of physical and emotional dignity.
Very true.
The exam will remind you that addressing the resident by their preferred name is a core part of respecting them during these highly vulnerable interactions.
This is such an overlooked detail. If a resident's chart says Margaret, but she introduces herself as Peggy, you call her Peggy.
Yep.
You don't call her Margaret because it's easier, and you certainly don't call her Sweetie, Honey, or Grandma.
Ugh, the pet names. That is a massive trap.
It happens all the time with the best of intentions. A young aide wants to show affection and warmth, so they use a pet name. But doing that strips the adult resident of their maturity. It infantilizes them.
It really does.
It reduces an 80-year-old woman who lived a full, complex life to a child. You use their preferred adult name.
Okay, so that's the standard baseline. But let's look at the nuances, because this is where the exam separates the good test takers from the great ones.
Let's do it.
Let's imagine a slightly unusual request. You are assisting a resident with toileting in their ensuite bathroom. You go to pull the door shut to provide that fortress of privacy we just talked about, but the resident puts their hand up and asks you to leave the bathroom door partially open instead of completely clicking it shut.
Ooh, a classic tricky scenario.
Right. Now, the textbook instinct in your brain screams, wait, the state regulations say I have to provide absolute privacy, I have to close the door, or I'll fail my skills test. What is the actual correct answer here?
The correct action is to honor their request and leave the door cracked.
Wait, really? Even though it violates the closed door rule?
Yes, because the resident is making an autonomous choice about their own privacy. This is a brilliant exam scenario because it pits the rigid rule of privacy against the foundational principle of autonomy.
I love this scenario.
It forces you to ask, whose privacy is it? It's theirs. The resident might want the door cracked because they are severely claustrophobic.
Oh, that makes sense.
Or maybe they want to be able to hear their favorite soap opera playing on the TV in the bedroom.
Yeah,
Or maybe they are just anxious about falling and they want the psychological comfort of knowing you are standing right there on the other side of the crack.
sure.
Whatever their reason is, privacy is a commodity that belongs to them, and they are allowed to control it. If they say leave it cracked, you leave it cracked.
And the distractors on a question like that are so tempting. One of the wrong choices will inevitably be tell the resident the door must be closed strictly according to facility rules.
It's a trap.
Facility rules do not override resident autonomy regarding their own body and space.
Exactly.
Uh.
Now, let's explore what it looks like when these rights are blatantly violated. The test makers will ask you to identify a clear violation of a resident's right to dignity.
Okay.
And one of the classic correct answers is using a bedpan for a resident in full view of visitors who are sitting in the room.
I mean, just pause and imagine the sheer visceral mortification of that. You have your son and daughter visiting you, you are having a nice conversation, and a staff member just walks in, rolls you over, and whips out a bedpan without asking your family to step out into the hall.
Without pulling the privacy curtain.
Right, without any warning at all. It completely strips the person of their humanity.
It reduces them from a respected parent to a set of bodily functions to be managed in public.
Contrast that blatant violation with a more subtle trap the exam uses. Imagine a resident asks you to close their bathroom door during a bath. One of the wrong distractors the test offers is, ask the charge nurse for permission before closing the door, since a closed door is a safety issue.
Ah, yes. The old ask the nurse for permission to basic human decency trap.
It gets so many people, because as a CNA student, you are drilled constantly to, report to the nurse and stay within your scope of practice.
Right, but you do not need a nurse's authorization to provide basic fundamental privacy. Privacy is a standard human right. It is not a medical intervention that requires a doctor's order.
You just close the door immediately.
You do. Now, if you personally have safety concerns, let's say the resident has a history of fainting, you manage the safety while maintaining the privacy.
How do you do that?
You stay right outside the door, you talk to them constantly through the wood to make sure they are responsive, and you ensure the emergency call light is physically in their hand. But you do not deny them the dignity of the closed door.
To help lock this in for exam day, let's introduce a quick memory aid for any question dealing with ADLs. That's activities of daily living.
Great idea.
I like to call it the knock, name, and nurture privacy rule. Whenever you face an ADL question, run through this checklist. First, you knock on the door and wait for an invitation. Second, you address them by their preferred name. And third, you nurture privacy by actively closing doors, pulling curtains until they overlap, and keeping their body appropriately covered with bath blankets while you wash them.
Knock, name, and nurture privacy. That is an excellent, comprehensive mental checklist. And it ties perfectly into one of the more emotionally complex scenarios you'll see on the exam.
Okay, what is it?
Imagine you are assisting a resident with highly personal hygiene care, perhaps peri-care, after an incontinence episode. And the resident quietly expresses to you that they are deeply embarrassed about their body and the situation.
Oh, this is such a tough one because human nature, especially for people who choose to go into healthcare, drives us to want to fix their negative feelings immediately.
We want to comfort them.
Exactly. Your instinct is to offer verbal comfort. You want to say, oh, honey, please don't worry, you look great. Or, listen, I do this 10 times a day. I've seen 1,000 bodies. It's totally fine. Don't be embarrassed. But the exam says that reaction is incorrect.
It is. The correct answer is not to overcompensate with flattery, and it's not to make sweeping comments attempting to normalize the situation.
Here's where it gets really interesting, though. Why is that? It feels so counterintuitive to not try to cheer them up.
Because if you comment on their body or the situation, even with the absolute best and warmest of intentions, you are actively drawing more attention to the very thing they're feeling intense shame about.
Oh, I see.
You are centering the conversation on their vulnerability. The correct approach on the exam and in real life is to perform the care in a calm, matter-of-fact, professional manner while fiercely protecting their modesty.
Matter of fact, I really love that phrasing. It means you don't make a big theatrical deal out of it. You work efficiently, you keep them fully draped with a bath blanket, exposing only the area you are currently washing. And your quiet, steady professionalism is what actually reassures them.
Exactly. Your competence is comforting, not empty platitudes. True professionalism is the ultimate protector of dignity in those moments.
Okay, so we've thoroughly covered protecting the physical body from view, but protecting the resident's information from view is just as critical.
Oh, yeah.
And honestly, it is way harder to do in practice because information is invisible. This brings us right into the realm of informational privacy and confidentiality. We are talking about HIPAA and OBRA regulations intersecting.
This is absolutely where the most careless, unintentional mistakes happen in a facility. The fundamental golden rule the exam will test you on is this. A resident's medical and personal information must be kept strictly private and cannot be shared without their explicit consent.
Right.
It cannot be posted on a whiteboard in the hallway for everyone to see, and it cannot be discussed with anyone, even other staff members, who do not have a direct clinical need to know.
Need to know. That is the magic phrase to look for on the exam. Let's break that down. Does the dietary aide preparing the lunch trays need to know that the resident has type 2 diabetes?
Yes, absolutely. They need that medical information so they can prepare a safe, carb-controlled tray.
Right. But does that same dietary aide need to know that the resident is currently estranged from their oldest son and hasn't spoken to him in 5 years?
Absolutely not. The dietary aide cannot use that social information to provide better food service. Therefore, sharing it with them is gossip, and it is a violation of confidentiality.
And the exam loves to test how you handle the accidental acquisition of this information. Like, there's a classic scenario where you were just walking down the hallway, minding your own business, and you accidentally overhear a resident in their room discussing a highly sensitive piece of their medical history with another nursing assistant.
That happens a lot.
You weren't eavesdropping, you just happened to hear it. What is your responsibility?
The natural human urge, unfortunately, is to share the secret. You go to the break room and say, "You will not believe what I just heard about Mr. Henderson."
Right.
But the correct exam answer is that you must keep that information completely confidential. You do not share it with anyone who does not have a medical need to know.
Even if it was an accident.
The fact that you acquired the information completely by accident does not give you a loophole. You are legally bound by HIPAA to lock that information in a vault in your brain and throw away the key.
This applies to information about your coworkers too, doesn't it? Like, the test might ask what you should do if you are at the nurse's station and you accidentally see a piece of paper containing confidential HR or medical information about another employee.
The protocol is identical. You avert your eyes, you keep the information private, and you do not mention it to anyone. Confidentiality applies to the entire building.
It also extends to the physical layout of the rooms. The exam might present a situation where a resident specifically requests that you do not discuss their medical condition while their roommate is present in the room.
This is a tricky one.
It is, because people often assume that since two people share a 200 square foot space, they essentially share medical information. Like, they're roommates, so it's fine, right?
But that assumption is a massive HIPAA violation. Each resident has an absolute individual right to privacy regarding their health information, even from the person sleeping 3 feet away from them.
So what's the practical solution?
If the doctor or the nurse comes in to talk to resident A about new lab results, resident B ideally should be asked if they wouldn't mind stepping out to the lounge for a moment.
And if they can't leave the room,
At the very least, voices must be lowered, and the physical privacy curtain must be pulled to minimize the chances of overhearing.
but, and this is a huge, bolded, underlined, but for the exam, confidentiality does have limits.
It certainly does.
It is not an absolute impenetrable shield in every single circumstance.
This raises a profoundly important question, and the exam will test your understanding of this boundary directly. Imagine a resident pulls you aside, looks you in the eye, and asks you to promise not to tell anyone about a personal matter they are about to share.
The correct action is to respect their confidentiality unless the information involves safety.
Exactly. If they tell you, "I used to be a semi-professional poker player, but please don't tell the other residents because I don't want them asking me to play," you keep that secret. That's a personal preference.
Makes sense.
But if they whisper to you, "My son pushed me against the wall yesterday when he visited, please don't tell the nurse because he'll get in trouble," what is your legal obligation?
The veil of confidentiality drops instantly. You cannot keep that secret. Any mention or suspicion of abuse, neglect, self-harm, or severe safety risks completely bypasses confidentiality rules.
Right.
As a healthcare worker, you are a mandated reporter. You must report that to the charge nurse or supervisor immediately.
Promising to keep a secret about abuse is not being a good confidant. It is actually a failure in your legal and ethical duty of care.
That is such a vital distinction for the exam. Now, let's talk about what is probably the single trickiest aspect of confidentiality for a CNA to navigate in the real world: family members.
Oh boy.
This is a huge exam topic because it causes so much friction on the floor. Let's imagine a scenario where a family member that wants you to help them keep a secret from the resident.
A very common real-world problem.
Right. A daughter pulls you into the hallway and says, "Look, we just talked to the doctor and mom's tumor is growing, but we know her. If she finds out, she'll just give up and get deeply depressed. So please don't tell her. Just avoid her questions if she asks why she feels so tired."
The exam is testing to see if you remember who your patient actually is. Your patient is the resident, not the daughter. The correct answer is that you must politely decline the daughter's request and explain that the resident has a fundamental right to be informed about their own medical care and health status.
You cannot collude with a family member to hide medical information from a competent adult. It violates their autonomy and it completely obliterates their right to informed consent.
Exactly. Now, let's flip that scenario around because the test will also do this.
Okay.
What if the family asks you to share information with them? You are in the room documenting care, and a family member walks up and asks to look at the resident's chart. Or they pull you aside and ask for specific details about the resident's latest blood pressure readings or infection status.
Wait, let me pause right here and play the role of the CNA on the floor. Let's say it's a daughter who visits her mother every single day.
Sure.
She is exhausted, she is devoted, she's clearly stressed out, and she just looks at me and asks, "Hey, what was mom's blood pressure this morning? Is that UTI finally clearing up?"
Right.
As a human being, as a 19-year-old CNA who feels terrible for this woman, isn't it just good customer service to give her a quick update? I mean, it's her mother. It feels incredibly cruel to look this crying woman in the face and say, "I can't tell you."
It feels terrible. It goes against every instinct we have to comfort people in distress. But legally, and on the exam, sharing that information is a violation. As a CNA, your required action is to politely direct the family member to speak with the nurse.
Even if she visits every day.
Medical information requires the resident's explicit, documented consent to share, even with a daughter who visits daily. The nurse is the one legally responsible for opening the chart, verifying that the proper HIPAA consent forms are signed, authorizing the daughter to receive updates, and then releasing the appropriate clinical information.
Yeah, this is exactly the kind of scenario CERT Prep Academy uses to test whether you really understand the rigid boundaries of HIPAA versus just wanting to be polite. Good customer service in a retail store means bending over backwards to give the customer what they want.
Right.
Good healthcare means fiercely protecting the patient's legal rights, even when it deeply frustrates or upsets their family.
There is a classic test scenario that drives this point home beautifully. A resident explicitly pulls you aside and asks you not to share any of their medical updates with a specific family member who is coming to visit later that afternoon.
Oh, wow. Okay. The correct answer there is straightforward, right? Respect the resident's wishes and do not share the information.
Yes, but look at how sneaky the distractors are. One of the wrong choices will say something like, "Share only the information that you think is important for the family to know for safety reasons."
That is such a dangerous, arrogant trap.
It really is.
It assumes the CNA has the authority to act as a filter and decide what is important enough to override the resident's explicit instructions. You do not have that authority. The resident is the absolute boss of their own information, period.
Absolutely.
And if we follow that logic, if a resident has the absolute right to control who knows about their care, it tracks perfectly that they have the right to control the care itself.
Which brings us to the right to refuse.
Yes, including the ultimate expression of autonomy, the right to say no. This covers refusing care, medications, meals, and activities.
And honestly, this might be the hardest right for healthcare workers to mentally digest.
Why is that?
Because our entire calling, our whole instinct, is to help, to heal, to provide the treatments that the doctor ordered. When someone looks at us and says, "No, I'm not doing that," it feels like a personal failure.
It feels like you aren't doing your job.
Exactly. But ethically and legally, competent residents can refuse almost anything. The exam will test your knowledge across multiple categories. They can refuse a basic clinical procedure, like having their morning blood pressure checked.
Right.
They can refuse their prescribed life-saving medications.
Yeah.
They can refuse to eat the meals provided. And they can absolutely refuse to participate in the facility's social activities.
So what is the actual protocol? What does the exam want the CNA to physically do when they walk into a room with a blood pressure cuff and the resident just shakes their head and says, nope, not today, get out?
The exam wants to see restraint. Your job is never to force the issue. You do not trick them, and you certainly never coerce them.
Okay.
Your role is to respect the choice in the moment, ensure the resident isn't in immediate life-threatening danger, and then promptly report the refusal to the charge nurse so it could be documented and assessed.
Let's explore the ethical boundaries of this using a scenario about food. A resident simply says they aren't hungry and refuses to eat their lunch. But their family happens to be visiting, and the family is frantic.
Naturally.
They are begging you, the CNA, to make the resident eat because they are losing weight. One of the trap answers the test will offer is sneak pureed food or protein powder into the resident's dessert or drink to increase their caloric intake without them knowing.
Oh, the sneaking food trap. Sneaking anything into a resident's food without their knowledge and without a highly specific, documented medical order and legal consent is deceptive, manipulative, and unethical.
So a hard no.
A hard no. It completely violates informed consent. Think about it. If you are willing to lie about putting protein powder in their applesauce, the trust is broken. What else are you willing to lie about?
That's a great point.
In that scenario, you respect the resident's autonomy to not eat, you politely decline to argue with the family, and you report the lack of appetite to the nurse.
Because the nurse needs to figure out the why.
Exactly. The nurse needs to assess the root cause. Maybe the resident has undiagnosed depression. Maybe a new medication is causing severe nausea. Or maybe their dentures are hurting them. You investigate the cause. You don't deceive the patient.
Let's look at another high-stakes refusal scenario. Medications. A resident refuses to take their morning pills. Let's analyze the wrong answers the exam might throw at you. One distractor might be, try to convince the resident for 30 minutes until they finally agree to take the medication.
There is a massive difference between brief, clinical education and coercion.
30 minutes sounds a lot like coercion.
It is. Spending 30 minutes badgering a resident until they give up and swallow a pill out of sheer exhaustion is coercive. It crosses the line.
And another trap answer is even worse. Crush the medication and give it to the resident anyway when they are not paying attention.
That is effectively administering a chemical substance without consent, which, in the eyes of the law, can be construed as battery.
Wow, battery. That's serious. So what does this all mean for the exam? It means any answer choice that involves hiding pills in applesauce or threatening a resident, like saying, if you don't take a shower right now, I'm not letting you watch television tonight, is automatically 100% wrong.
You cannot use punishment or deception to gain compliance.
But this brings us back to our most difficult variable, dementia. The exam will inevitably ask what you should do if a resident with moderate to severe dementia is aggressively refusing necessary hygiene care, like a shower.
Right, because if they have dementia and they are covered in feces, you can't just say, okay, you're exercising your autonomy by, and leave them dirty in their bed for a week.
No, that's a neglect.
Exactly. The balance shifts, but the respect remains. When a resident with dementia refuses care, the correct exam answer is to utilize alternative approaches.
Alternative approaches, like what?
You have to act like a detective. Why are they refusing? Maybe the bathroom is freezing cold because they've lost the ability to regulate their body temperature. So you try turning up the heat. Maybe the sound of running water echoing off the tile sounds like a terrifying waterfall to their altered sensory processing. So you turn off the shower and offer a quiet, warm sponge bath in bed instead.
That makes a lot of sense.
Or maybe they're just having a catastrophic reaction to being rushed. So you leave, play some soft music, and try again in an hour. You try different gentle approaches. You involve the nurse for guidance, and you document everything. But you never, ever use physical force to overpower them and make them comply.
I want to give our listeners a mental framework for handling any refusal question on the exam. Let's call it the 3 R's of refusal.
Oh, I like this.
When a resident says no to anything, you do 3 sequential things. First, you recognize the right. You mentally acknowledge that they are allowed to say no.
Step 1, check.
Second, you respect the choice. You don't argue, you don't retaliate, you don't trick them. And third, you report to the nurse.
Recognize, respect, report.
Exactly. Recognize, respect, report. If an answer choice violates any of those 3 steps, it's the wrong answer.
That is a phenomenal framework to carry into the testing center.
Now, so far we've talked a lot about autonomy as a defensive mechanism, the right to refuse things, the right to keep people out. But autonomy is also about proactively choosing the things you do want.
Right. It's about how you design your daily life.
Exactly. This moves us into the realm of daily choices, property, and the living environment.
As independent adults, we often take for granted how much our tiny daily choices define who we are. Think about clothing.
Right.
The exam will present scenarios where a resident insists on wearing their own personal clothes, even if they're slightly mismatched or difficult to button, instead of a convenient facility gown.
And the test wants to verify that you understand this reflects their fundamental right to make decisions about their appearance and identity.
Yes,
Going back to our hook at the very beginning of this deep dive, the horror of being forced into a hospital gown, clothing is armor. It's expression.
it really is.
Supporting a resident's choice to wear their own favorite sweater, even if it takes you an extra 5 minutes to help them get it over their head, is a profound act of preserving their dignity. Unless there is a highly specific, documented medical necessity, like they have bulky surgical drains, that only a loose gown can accommodate the resident's wardrobe preference rules.
And that concept extends to their physical space too, personalizing their environment. You might see a scenario where a resident wants to keep a framed family photo on their nightstand.
Pretty standard.
Right. But you walk in for your shift and notice the photos have been removed by another staff member because they were cluttering up the table.
The correct action on the exam is not to just shrug and say, oh, well, less for me to dust. The correct action is to report the removal to the nurse or supervisor immediately.
Because it's not just a minor housekeeping issue, it is a direct violation of the resident's property rights.
Technically, it is unauthorized removal of property. It's theft. And another massive property issue the exam loves to test involves medical equipment, specifically dentures.
Oh, dentures are a huge topic.
Imagine you notice a resident's dentures are sitting in a cup, and they are completely unmarked. No name, no room number.
The required action is to notify the nurse to ensure those dentures are properly labeled immediately.
Why is this such a big deal on the exam? Like, why focus on dentures?
Because dentures are not just plastic. They're incredibly expensive, highly personal, and absolutely vital to a resident's ability to eat solid food and speak clearly.
And if they're unmarked?
An unmarked set of dentures is highly likely to get accidentally thrown away on a lunch tray or mixed up in the laundry. Proper identification prevents loss, which directly protects the resident's property rights and their nutritional health.
What about financial property? Let's say a resident wants to keep $100 in cash in their bedside drawer so they can buy snacks from the vending machine instead of depositing it into the facility's secure trust account.
Okay, another tricky one.
Right. I've seen test takers argue this. They say if the resident has cognitive decline, letting them keep cash in their room is totally irresponsible. What if it gets stolen? Isn't the facility liable? We should mandate that they use the locked trust account. What does the exam say?
The exam says the resident has the right to manage their own finances. You cannot physically confiscate their money.
But isn't there a risk?
There is. So the correct action for the CNA in that scenario is to report the situation to the nurse or the social worker. The facility staff has a duty to sit down with the resident, explain the risks of keeping cash in the room, and offer the secure trust account as an option.
So you advise, you educate, you offer safeguards.
Yes, but you cannot unilaterally take their money away.
Cert Prep Academy actually has a lot of resident rights questions in their bank, specifically about clothing and personal items, because it's so easy to overlook.
It really is.
We get so laser focused on the life or death medical stuff, like the blood pressures, the oxygen levels, that we forget that a lost pair of reading glasses or a missing photo album can be absolutely devastating to a resident's psychological quality of life.
That's a great point. And beyond physical items, residents retain robust social and spiritual rights. The facility is obligated to accommodate their right to practice their religion privately.
Right.
They have the right to receive visitors at reasonable hours. The facility cannot just arbitrarily ban a resident's friends from coming to see them.
They also have the right to private communication. If a resident's son visits and they want to talk, you step out of the room. You don't hover in the corner pretending to fold towels while listening in to their family drama.
No eavesdropping allowed. And here is a very common, highly realistic scenario you might face on the test. A resident is assigned a new roommate, and they simply do not get along. They argue constantly. The resident formally requests a room change.
Oh man, I have lived with bad roommates in college. It is absolutely miserable. But in a college dorm, you can leave. You can go to the library or a coffee shop to escape. In a nursing home, especially if your mobility is compromised, you are trapped in that 200 square foot box with that person.
Which is precisely why the correct exam answer is that the resident's request should be respected, and the facility administration must actively work toward accommodating the room change as soon as a bed becomes available.
So you don't just tell them to deal with it.
No. One of the wrong distractors will say, tell the resident they just need to compromise and work it out. You cannot dismiss their distress. They have a right to exercise choice regarding their living environment.
But this leads us to what is arguably the most dramatic tension you will face on the floor. What happens when the resident's choices violently clash with what their family wants for them? We have touched on this briefly, but we need to dive deep into family conflicts, proxies, and advance directives.
Yes, because this is where the exam gets really naughty.
It does.
The absolute foundational rule to remember for every single one of these questions is the concept of competence. If a resident is legally, mentally competent, their choices completely and totally override the wishes of their family.
Period. End of sentence.
Yes. Let's look at a scenario. An adult son approaches you at the nurse's station and demands that you restrict his father from using the hallway phone. The son says he keeps calling his old drinking buddies and they just upset him. Do not let him use the phone.
The correct answer is to inform the nurse of the son's demand, but ultimately the resident has the right to unrestricted communication. The family cannot establish a communication blackout just because they find Aunt Susan or the old drinking buddies annoying.
Here is another classic. A competent, alert resident wants to participate in the Friday night bingo game in the dining hall, but their daughter intercepts you and says, please stop him from going to bingo. He didn't sleep well last night and he needs to rest.
Okay, so let me get this straight. If a family member tells me, don't let my dad go to bingo, he needs to rest, but dad is alert and wants to play bingo, I listen to dad, right?
You absolutely listen to dad. You allow the competent resident to make his own choice about his social activities. The daughter's preferences, no matter how loving or well-intentioned they might be, are entirely secondary to the resident's autonomy.
That makes total sense.
We see this with privacy, too. Imagine a family member insists on staying in the bathroom to supervise while you're giving the resident a shower. But you can tell the resident is visibly uncomfortable with their child watching them be bathed.
You pause, you look directly at the resident, and you ask them what they prefer. If the resident says they want privacy, you turn to the family member and politely ask them to step out into the hallway.
Exactly.
In that room, you are the resident's advocate and protector. You are not the family's concierge.
Now, we have to address the flip side of this rule. What if the resident is not competent? What if they have suffered a massive stroke or have end-stage Alzheimer's and truly legally lack the capacity to make safe medical decisions?
The test will ask you who has the legal authority in that situation. And I can tell you right now, the wrong answer, which is usually choice C, is whichever family member visits the facility the most frequently.
That is a trap. Frequency of visits does not equal legal authority. If the resident is incompetent, the authority falls to their legally appointed guardian or their designated healthcare proxy. This is sometimes called a medical power of attorney.
It's a formal, legally documented role.
Yes. That specific person, and only that person, steps into the shoes of the resident to make decisions on their behalf.
And speaking of legal documentation, as a CNA, because you spend more time with the residents than anyone else in the building, they will sometimes talk to you about end-of-life planning.
That happens.
The exam might present a scenario where a competent resident starts asking you how to set up a living will, an advance directive, or even a last will and testament for their physical belongings.
The exam wants to test your understanding of your scope of practice. Your role as a CNA is absolutely not to provide legal advice. You do not help them draft a will on a piece of notebook paper. That is way outside your scope.
So what do you do?
Your role is to respectfully listen to their request, validate their right to manage their affairs, and inform them that you will have the charge nurse or the facility social worker come to their room to provide the correct legal resources.
What you don't do is shut the conversation down. You never want to pick the answer choice that says, oh, don't talk like that. You're going to outlive us all. That is incredibly dismissive of their autonomy and their mortality.
Right. You listen and you refer.
The same rule applies if they express a desire to donate their body to medical science after they pass. You listen, you document the wish, and you inform the nurse. You do not insert your own religious or personal judgment into their decision.
So we have established throughout this entire conversation that residents possess all of these robust, legally protected rights. But a right is essentially meaningless if there is no mechanism to enforce it.
Exactly.
What actually happens when one of these rights is violated, whether it's by a careless staff member, an overbearing family member, or a systemic failure of the facility itself?
That is the perfect transition to our final major topic area. If a resident's rights are violated, what is the mechanism to fix it? We need to talk about grievances, abuse recognition, and maintaining safe environments.
Let's start with the formal grievance process. Imagine a resident is deeply unhappy with how long it takes staff to answer their call light, and they want to file a formal complaint with the state ombudsman.
They have the absolute right to voice grievances and file formal complaints without any fear of retaliation or discrimination from the staff. As a CNA, if a resident tells you they want to complain, you listen respectfully, you provide them with the contact information for the ombudsman if they ask for it, and you report their concern to your supervisor.
You do not try to talk them out of it.
Right. You don't try to guilt trip them by saying, please don't complain, we are just really short-staffed today and everyone is trying their best. You facilitate their legal right to be heard.
And part of having rights is the baseline expectation of living in an environment that is fundamentally safe, clean, and comfortable.
Yes.
The exam might ask you to identify a scenario that violates the right to safe and comfortable living conditions. A glaring correct answer is leaving a resident lying in soiled bedding for an extended period.
It is crucial to understand that leaving someone in a wet bed is not just an example of poor time management or sloppy care. On the exam, it is classified as a literal human rights violation under OBRA.
It strips them of their dignity, it rapidly damages their skin integrity, and it creates a highly unsafe, unsanitary environment.
Let's transition to psychological safety because the exam tests this rigorously. There is a scenario that unfortunately happens in the real world. You are walking past the nurse's station and you overhear several staff members laughing, joking, and making fun of a resident's recent incontinence episode.
It's terrible, but it happens.
It makes my blood boil just thinking about a situation like that. And the exam will ask you how this behavior should be classified and handled. The wrong answer will try to minimize it by calling it harmless staff gossip or blowing off steam.
There is no such thing as harmless gossip when it comes to a patient's bodily functions. The correct answer is that this is a direct violation of the resident's right to dignity and respect. It is a form of verbal and psychological abuse, and you are legally mandated to report it to the charge nurse immediately.
But what if the accusation is leveled against you?
That's a scary thought.
This is perhaps the most terrifying scenario on the exam. A resident points a finger and accuses the CNA, meaning you, the person taking the test, of rough handling or mistreatment.
When you are falsely accused of something, human nature instantly kicks into fight or flight mode. Your heart rate spikes. You want to defend your character. You want to argue with the resident and prove that you didn't do it.
I remember seeing this one on Cert Prep Academy. The instinct is to get completely defensive. You want to pick the answer that says, explain to the resident that they are confused and that you would never hurt them. But the right exam answer is always to report the accusation to the supervisor immediately and cooperate.
On this exam, minimizing a complaint, passing the buck, or getting defensive and arguing with a resident is always the wrong choice.
Always.
The regulatory system is designed to protect the most vulnerable person in the room first. By stepping back and cooperating with an investigation, even when you know you are innocent, you are demonstrating profound professional maturity. You are showing that you respect the process that keeps all residents safe.
Exactly. You are essentially saying through your actions, I value this person's right to feel safe and their right to be heard, so much that I welcome my supervisor looking into this.
Let's look at one final massive right that really ties everything we've talked about today together. It is the ultimate trump card of autonomy.
Okay, what is it?
Imagine a resident who is mentally competent, decides they hate the facility, they pack a duffel bag, walk down to the lobby, and state that they are leaving the facility against medical advice.
AMA. Against medical advice. They just want to walk out the sliding glass front doors and never come back. Can they legally do that?
Yes. A long-term care facility is not a prison, and it is not a locked psychiatric ward unless there are very specific, legally binding court orders in place. A competent adult resident has the absolute right to leave the building.
So what is the CNA's required action in that moment? Because your instinct is to panic. Do you physically block the door? Do you grab their arm?
Absolutely not. You never touch them, restrain them, or physically block their exit. The appropriate action is to immediately urgently inform the charge nurse or the facility supervisor.
The nurse handles the legal side.
Yes, the clinical and administrative team needs to step in quickly to talk to the resident, explain the medical risks of leaving without a discharge plan, ensure the proper AMA legal documentation is signed to release the facility from liability, and try to arrange safe transportation.
Wow.
Your role as a CNA is not to stop them. Your role is to urgently activate the facility system to ensure their exit is as safe and legally documented as possible.
Okay. Wow. We have covered a truly massive amount of ground in this deep dive today. We've gone from the dark history of the 1970s all the way to the legal mechanics of leaving against medical advice. Let's do a tight 1-minute recap of the 4 core takeaways you need to have locked in your brain before you walk into that testing center.
Number 1. Residents never, ever lose their human rights simply because they signed admission papers to a facility or because their brain changes due to dementia. Autonomy and dignity are permanent fixtures of their care.
Number 2, you must proactively build fortresses of privacy. This means physical privacy, like knocking, closing doors, pulling curtains so they overlap, and informational privacy, like following HIPAA, keeping charts closed, stopping gossip, and redirecting all family medical questions to the nurse.
Number 3. Respect the right to refuse. Whether it is morning medications, a lunch tray, or a shower, your job is to utilize the 3 R's. Recognize the right, respect the choice, and report it to the nurse. You never force and you never use deception.
And number 4, when family conflicts arise, always prioritize the wishes of a mentally competent resident over the convenience, anxiety, or preferences of their family members. You are the resident's advocate.
Before we go, I want to leave you with one final thought to mull over as you continue your studies.
Oh, I'm ready.
We have spent the last hour talking extensively about the rules, the regulations, and the laws. But I want you to think about how the design of a nursing home itself, the physical architecture, the long, sterile institutional hallways, the small shared bedrooms, the loud, echoing intercom systems might unintentionally challenge these rights daily.
That's a great point. The building itself is an obstacle.
Yes, and I want you to think about how your presence as a CNA is the bridge between an institutional building and a true, dignified home for that resident. You are the counterbalance to that architecture. Your warmth, your willingness to just take 2 seconds to close a bathroom door, that is the guardian of that bridge.
That is an incredibly powerful way to look at it, and it is exactly the mindset you need to walk into that exam room with.
I completely agree.
Before we officially sign off, if you want to test yourself on exactly these kinds of tricky, emotionally complex, scenario-based questions we've been discussing, you need to head over to certprepacademy.com. The platform is completely free. There is absolutely no sign-up required to get started, no emails to enter, and no credit card nonsense. Just go to the site and start practicing immediately.
It's an amazing resource.
It really is. They have a full 70-question practice test that perfectly mirrors the real NNAAP exam, plus free study guides covering every single topic on the test, and flashcards to help lock in all these key terms we broke down today. Everything you need to pass this exam is sitting in one place, and it costs absolutely nothing. Go to certprepacademy.com right now. The link is waiting for you right there in the description.
Good luck studying, everyone.
We are so incredibly proud of the work you are putting in. Preparing for this career is hard, emotionally draining work, but you are doing it. Next time, we are moving on to episode 10 of our series, where we are going to pivot from ethics back into hard clinical skills, data collection, and reporting. Keep studying, keep trusting your clinical judgment, and we will see you right back here for the next deep dive.